Good afternoon, Dr. Karume. I just want to check my sound. Good afternoon. Can you hear me?
Yes, I can hear you very well. This is Janet. I can hear you.
Okay, thank you, Dennis. Good afternoon, everybody. Thank you for joining in good time. We are just waiting for one of our speakers, and then we'll be ready to start this webinar. Karibuni. Good afternoon once again. I believe we're ready to start. Welcome to this session on elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. My name is Dr. Anne-Marie Masharia. I'm a pediatrician, infectious disease specialist at Kenyatta National Hospital, and I will be the moderator for this session. So I'll start us off by introducing our panel of eminent speakers. Dr. Francis Ndwiga will be making the first presentation. He is the Pmtct Program Manager at NASCOP, and he will be giving us an overview of where we stand in this journey in the country to date. Our key speaker is Professor Ruth Ndwati, who needs no introduction. I believe she's known to all of us. She's a professor in the Department of Pediatrics and Child Health at the University of Nairobi. She's also a member of the NASCOP Technical Working Group on PMTCT, as well as pediatric and adolescent HIV. Professor Ndwati is a pioneering researcher in the field of HIV with over 30 years experience. She's well published in this area, as well as in the area of other infectious diseases. And I can tell you she's passionate about children and particularly about breastfeeding, and we look forward to hearing more from her. After that main presentation, we will hear from Dr. Alfred Osoti. Dr. Osoti is a senior lecturer in the Department of Obstetrics and Gynecology at the University of Nairobi and an affiliate associate professor at the Department of Global Health in the University of Washington. He holds an MD-CHB and Masters of Medicine in Obs-Gyne from the University of Nairobi, as well as an MPH and PhD from the University of Washington. He's a clinical researcher with interest in high-risk pregnancies and PMTCT, and is a principal investigator of NHIF-funded grants and co-PI in multiple grants. He's also published his written articles on PMTCT and book chapters. We will also have Dr. Christine Karanja Chege, who is a pediatrician and infectious disease specialist, who holds a master's in pediatrics and child health from the University of Nairobi, and a pediatric infectious disease subspecialization from the University of Oxford. And she's also pursuing a doctorate in global child health from the University of Amsterdam. Christine is a lecturer at Kenyatta University, and she's passionate about child health, vaccines, and infectious diseases, and she's part of the team in many private institutions. So welcome to this session. We are going to have two main presentations, and I ask you to either type your questions in the chat box, and then we will just have a plenary session once all the speakers have gone through. So karibu, Dr. Ndwiga.
Thank you very much for that nice introduction. My name is Francis Ndwiga. I work at the Ministry of Health as the program lead for Pmtct STI. And I'm really happy to have you here to really have a feel of the Pmtct program in the country and where we are in terms of Pmtct elimination agenda. With that, I would allow maybe our other members that had shared, maybe Dr. Kinuthia, to really display the presentation so that you can be able to go, and I'd share the presentation area.
Okay, give me a minute.
Okay, thank you.
Please give our main presenter a few minutes to just put up his slides. Thank you.
Thank you, Dr. Kinuthia. I think you can put it in a slide mode. And maybe as you do that, I can be able to start. One of the things that I want to report is that elimination of mother-to-child transmission is one of the key national priority agenda that the NASCOP and other stakeholders are taking leadership in terms of spearheading the elimination agenda in this country. And we have been able to appreciate the fact that the elimination agenda in terms of the triple elimination will cover 3 diseases together, based on the aspect that these are the key areas that have also been highlighted in the global strategy to actually for us to focus on, looking at areas of how we can be able to eliminate that. So as I start this, I think I really appreciate being the first webinar series. We will be able to go through some of the key areas and where the national government is and the performance and the areas that we really need to focus on. To start us up is that the presentation that I do today, I'll be able to give the background, the estimate overview of the program, the sources of new infections that we didn't need to focus on, and I'll also be able to highlight the key agenda in terms of how we want to go about it, specifically looking at the criteria for elimination, which is also one of our tasks that we also need to undertake. So we can
Dr.
go to the
Ndwiga,
next.
we can now see your slides in slide mode. I think you can go ahead. Thank you.
Okay. Thank you, Dr. Kinuthia, for that, and you'll be able to assist in terms of controlling the slides. I'm saying that in terms of our presentation, we'll be able to give outline in terms of the background, the estimate overview of the program, and also the sources of new infection that we didn't need to focus on based on the tools that we are using to really identify areas of concern and also the uniqueness of this program. And more importantly, we'll also be able to share the criteria for validation, which is one of our tasks that we have been tasked by the ministry to make follow-up and ensure that we achieve the elimination agenda. The next slide. Yeah, I want to give the background in terms of program where we are. We know that very well. Our concern is actually to give a chance to every child to have a healthy life and also be free from any preventable communicable diseases. And that's our key mandate as the Minister of Health in terms of looking at elimination of mother-to-child transmission. And we want to say that we align this to the global health strategy for women, children, and adolescents. And this basically looking at the document that is still existing, 2016-2030, that aims to really look at how we can be able to optimize and achieve the healthy standard as well as the well-being of the children, and which is also in line with our constitution, especially specifically Article 43 of the constitution. But similarly, we know very well that the WHO has also been able to ensure that we can be able to interlink the global health strategies that are there for HIV, viral hepatitis, and sexually transmitted infections, specifically looking for a program whereby our interest will be more in all the diseases, but more specifically, one of the key indicators being the Sphyllis component that is very important. This is in line with the 2016-2021, and which is also captured in our national strategic framework for the country, specifically looking at the Pmtct program. The next slide. How is the situation in Kenya? We can say specifically that Kenya is one of the countries in sub-Saharan Africa that account for a number of pregnant women living with HIV. And here we say that in terms of looking at the number for the known positive is an average of more than 75%. And that tells you that our concentration for people who are living in HIV, specifically for women, is very important for us. Therefore, there is need to ensure that triple elimination, looking at the data and also aligning to the global strategy that is there, the three diseases are very important for us to ensure that we focus and invest all our effort in terms of elimination of the triple elimination. We know that it's a burden to all of us, and statistically, we can also be able to say that the burden is high, and we also need to see how we can be able to eliminate based on the indicators that are there as a program. Chronic hepatitis B virus is very significant as one of our health problems in Kenya, and we really need to align our effort to that agenda. The next slide. Our reference is that one the document that we have in terms of the reference that is there is that if you look at the KNH-UoN 2018, it really demonstrates, actually demonstrates that the viral hepatitis is one of our biological markers, and the result shows that chronic hepatitis B and acute hepatitis B, the prevalence is around 4%, which we also say that based on that, we also need to ensure that we have a program that focuses on elimination and also prevention of that disease. For that, it tells that the HIV prevalence among women is around 5.6 by then. That was 2018 compared to men. So our focus mainly, we believe that people who are HIV positive have higher prevalence of getting hepatitis B. So for women, we really need to see how we can be able to focus and also considering the other generation that is there. More to that is that quality prevention and treatment interventions will be one of our key, looking at how they can also be done by skilled professionals for the right decisions within the component of FITO to ensure that our children starts with the free and stay free from HIV AIDS. Kenya, for now, we believe that our focus is to lower the Pmtct rate through empowering our health workers and also looking at how we can really be able to expand the component to the community for us to get quality service delivery to our population. The next slide. We believe that triple elimination is one of our key strategies as a program, and is well captured in our new being revised framework. And we believe that by definition, triple elimination is an initiative that supports Pmtct, whereby the focus is the three diseases, as said. But more importantly, what would be our markers in terms of the indicators? The agenda that we have and the goal that we have is that the Pmtct rate must be below 5% as one of our Pmtct goal. And we also believe that our prevalence rate for hepatitis, especially specifically looking at the antigens among children should be 0 to 1%. And also our marker for indicators that we are looking at in terms of our performance is that we need to have less than 50% of syphilis cases per every 100,000 arrived births. But in terms of our program, what we are looking at is that our agenda is actually to go below 5%. So the effort that the counties and the national government is putting to ensure that our effort accounts for our goal is actually below 0%. But I know some of the counties are doing more effort and are achieving the high performance in terms of intervention that have been set. Significantly, the progress in triple elimination has been made in the region, but more progress is required. And we believe that in the region that we are living in, there are lessons we can learn, there are efforts we can learn, and more importantly, there is what we can also be able to ensure that we are model that other countries within sub-Saharan Africa can learn from, especially looking at the highest burden of these diseases within the region. The next slide, please. So the program is more than 3 decades, the Pmtct program, and we believe that we have been able to do much in terms of looking at where the journey started. We know that back in the late 90s, I thought about Pmtct program being initiated in this program was one of our key agenda at NASCOP level, but also aligning that to the global towards elimination. We also believe that we are able to keep our children and our mother alive as one of our key agendas. Our ambitious targets, including the reduction of new infection, is one of the key agenda, and we believe that this is one of the agenda that all of us will be able to work on as a country and also as our technical team. The next slide, please. Where are we in terms of HIV epidemiology? We can say that if you look at the epidemiology of Kenya in terms of HIV, we really believe that some counties are doing well, and the prevalence rate between men and women, you can see that the normal average for a general population is around 4.3. But more important that it can tell you that the prevalence rate for women is around 5.5 and for men is 2.9. So that variance can tell you that there is focus that is required, more focusing on the areas of women. But in terms of Pmtct, if you look at where we were back early 2000, it can tell you that in early 2000, the program was being initiated. We were at around to that 5% of our Pmtct rate, but effort has been put, investment has been there, and by 2020 we are at 9.7, and currently the preliminary results that we have are around 8.4%. This has been made because of the effort that had been there, but besides that, there is a population that is also giving us a lot of contribution to HIV in this country that we also need to really focus on, especially focusing on young adolescents. Is one of the programs whereby we are saying that 42% of new infection occur among this age, that is 15 to 24. And effort is required to ensure that some of these key areas of contribution to the new infection is well taken care of. In terms of where we are, we can say that between 0 and 14, the current number of children that are HIV positive is around 78 for 65%. And what we are saying within that program is that effort is required to ensure that none of these children that we are taking care of at pregnancy level will be able to transit to that other level. So our effort is required. Management of the people living with HIV is required, and our targeted program require that we really invest in those areas. The next slide, please. I want to say that triple elimination initiative is an initiative that all of us are really supporting, and I don't want to repeat. One of the key indicators for us to focus on this and the justification we have is that the features of the 3 diseases are shared, and including epidemiology and disease interaction and core interventions for tackling them is one of the areas that we really need to focus on by strengthening integrated health systems approaches, which also are client-centered and also which are community-led. So we want to see what are key things that within our systems that we really need to do differently and what is new in terms of our strategic shift in terms of management of these three diseases. One of the efforts we have been able to is to ensure that we revise our policies, we ensure we have targeted approaches, and more finally, we also look at how are we able to capture the required data that can indeed be able to inform the program, looking at issues around evidence-based and also coming up with the best priority in terms of our research agendas. The current barriers for this is usually around the resources and the strategies that we are able to develop. But I'm sure that for us to have a well-established preventive and treatment intervention, we have been able to come up with the best coordination mechanism, looking at how we have technical teams and also how we are able to empower our counties to be able to take charge of this agenda. So for us, we have strategies, but we also have challenges in terms of resources to really manage this or support the uptake of this. But more importantly, we also have to empower our lower levels. The next slide, please. So I want to say that in terms of the preliminary results for HIV estimate, it can, if you look at 2018 and 2019, we can also see the effort that the government is putting to ensure that we reduce the prevalence rate in this country is well demonstrated. But more importantly, for us as PMTCT program, what I want to say is that the MTCT rate is still high. This is 10.8 at 2020. And the current preliminary result we will be able to discuss in the next slide. But more importantly is that we also need to promote the ART coverage, which has been highlighted there to a higher level. Our global target or our key target is above 95, and it can tell you that the current ART coverage is at 80%. So we need to put more effort and ensure that we link our mothers to care and we link the general population to care, and also ensure that we have a well-sustainable retention program for all those people who are on care. The next slide, please. In terms of PMTCT, we really believe that PMTCT rate is still high for us. And one of the key things that it can demonstrate is that there are more effort that is required in terms of ensuring that we have a well-defined and a well-supported monitoring mechanism. If you look at EID in 2020, in 2021, we were able to do 100 first test for EID, but if you look at the 2 months, we were almost at around less than 50% or somewhere there, around 56% of that. That tells you that there is a gap, and monitoring of this is required so that we can be able to program. We know the challenges that were there, but I know that currently we have been able to ensure that for us as a program, we have sufficient supply of commodities. We have been able to build capacity. We have trained our people. We have been able to engage, continuous engagement to build that capacity for all of us to really be focused. In terms of PMTCT, I can say that the current data that we have, which is preliminary, we are at around 8.3. That's a great, but our target still remains. In terms of uptake for ART, our target is above 95%, but in terms of PMTCT, if you look at where we are in terms of identification, which is the first 95, is that we are doing well, but we really believe that in some areas, we really need to put more effort and be focused. But more importantly, if you look at the Sphyllis, we are at modest in terms of testing, where we believe that at TNC level is still low. Some of the key factors that may have contributed to 63% are really related to issues around commodities, are also related to ensuring that we have access to service, and also ensuring that quality counseling and the quality support for our mothers is well done. So we need to look at what are these teething problems, what are these gaps that are there for us to ensure that we achieve 100% in terms of coverage for Sphyllis testing within our program. The next slide, please. So preliminary results tells us that if you look at these slides, it can really be able to give us where we are in terms of PMTCT. Our need for PMTCT for 2021 was around 52,042. And then the people who are actually receiving PMTCT was around 52,573. That tells us that the program was really doing very well. But more important to that, it can tell you that Pmtct rate at 6 weeks is at around 4.2%. But as we move forward in terms of looking at the program, and especially looking at the postnatal level, is that our program continue increasing in terms of Pmtct rate. So we need to see how we are able to invest and look at interventions that will be able to give us good outcome, especially at the postnatal level and more specifically at the breastfeeding period. The next slide, please. So these are just a summary of where counties are and what the performance that we can really be able to report. And the key thing with this kind of discussion or sharing is that counties are at different levels. Counties are able to be categorized in different levels. And this one of the key metrics that we really share with the counties in terms of where they are. This one, if you look at the green levels, the counties are above 90% in terms of program performance for specific indicators that are there. But more importantly, if you look at the red, it identifies that there are more effort that is required at specific areas of focus. And more specifically, I want to look at the proxy Pmtct HIV exposed infant, whereby some of, in terms of less than testing at 2 months coverage is a bit low. We know the challenges that are there, but for us as a program is area that we really need to focus on. Though the proxy Pmtct HIV exposed infant is one of the areas that we really need to focus and look at. One of the key things we have been able to initiate is resumption of both viral load and also ensuring that our EMTCT testing and monitoring is resumption is done within our program. So this one gives just a picture of what is happening at the county level, and also to give the counties an opportunity to be able to identify the areas that more effort is required. The next slide, please. So the next slide, please, it actually covers the other counties. I still the same picture that is also demonstrated, and I believe that this one gives us an opportunity for all of us to look at that in terms of the effort. The next slide, please. So in terms of maternal cascade for January to November last year, this one I just wanted to share to demonstrate where we are. One of the key things that I really wanted to identify here is the issue around missed opportunities. We have a significant number that is required. Effort has been put to ensure that we are able to identify these missed opportunities and also be able to reach these mothers. One of the key things that is happening is that we have been able to have a regional kind of a targeted approach to look at those, and also county specific, and even going lower to the facilities to be able to identify this missed opportunity. But more importantly, generally, a number that is also portrayed here is around the unreached mothers. So we need to actually have a component of community to be able to identify these unreached mothers, and also look at what are the key systemic gaps that are within our systems that can also be able to give us this significant number. So this one defines that we have a job to do in terms of missed opportunities, and also in terms of access to care for the unreached mothers, and effort is required in terms of how we can be able to draft the best strategies. The next slide. This one is one of our best tools that we use, and specifically this one is the stack bar analysis. The stack bar is really one of the tools that we use as a program that gives us direction in terms of areas of focus. The tool really gives us what are the areas that we really need to focus our energy, defining the new sources of new infection. If you look at this stack bar for 2018, which is not different from others, and we are trying to get the latest within our program, is that it tells us women who did not receive ART actually contributed to around 10% of our new infections. But more importantly, it also gives us that beyond that infected during pregnancy and also breastfeeding combined contribute to around 23% of our new infection. So these are areas of new acquiring HIV infection that we really need to focus on. That's why the prongs and also the effort beyond delivery is also required. But more importantly, there is also a bigger component of people who have started on treatment, but they're discontinued at some level. So this effort is also required for us to ensure that all mothers and the detention program that we really need to ensure that we sustain and detain our mother-only care is very important. But also on the other side, there are different levels and categories in terms of proportions of contribution of different indicators that we didn't need to focus on, and this one gives us a summary of how we can be able to come up with the best interventions for this program. The next slide, please. This slide gives us one of the journey that is there that we usually put as a reference for us to ensure that the program is in progress. And one of the key things is that it's a journey since 2012 up to where we are and where the target is. And I don't want to labor on this because one of the key things is where we are even up to 2020. Our vision still remains that we really need to achieve our target of elimination below 5%. So this one gives us a journey that the effort and also lessons and also experience in terms of programming need to be packaged for us to ensure that we really either maintain or identify what needs to be done differently as a program, and also identify what are the key other population of interest that we really need to focus on. The next slide, please. As we move this program forward, one of the key areas that the national government and the ministry is focused on is actually to initiate the discussion, the conversation, and the program around validation of elimination of agenda based on the key elimination agenda aspect that we didn't need to initiate in this country. One of the key is the standard criteria that is set by WHO that we have been able to initiate. And this, what we have been able to do is to establish a national validation committee at the national level, led by NAC and NASCOP and other key stakeholders to ensure that this initiative is initiated. There are key different processes and key different impact criteria that will give us that direction. We have been able to look at two levels. One is the issue around elimination of HIV and also Sphyllis. So for us, we'll be able to start the pre-validation process together with other stakeholders to ensure that one of the agenda for the country is well done and ensure that our processes and our impact criteria is well. So for this, I was just sharing to give us a direction where the national government is taking the elimination agenda in terms of ensuring that we initiate this as per guided by the WHO criteria. The next slide, please. So in terms of program consideration, as we finalize our presentation, is that they are key. We have been able to achieve much with the existing tools, but what we believe is that we need to have now new products in terms of service delivery and also in terms of interventions. But more importantly, we also need to look at new models of care that we didn't need to initiate. We have been in an emergency mode, and currently we need to think about management of a chronic disease model that will be able to define what is sustainable and what we can be able to do. Also, in terms of the models of service delivery, we need to really look at different uniqueness and different modes that can really be able to give us. So with that, what we have been able to initiate is that one of the weak links is to come up is the research agenda. So for us, we have been able to prioritize research agenda as one of our key areas to inform the program and really be able to assist us in terms of accelerating the progress for treatment elimination. But more to that, in terms of healthcare system, we really need to see how we can be able to strengthen the link between the healthcare system and the community for us to be able to come up with a sustainable model for elimination. But more also importantly, political support and resource allocation, looking at how we can be able to come up with a more efficient way of management for us to succeed in the program will also be very important for us. So in terms of our consideration, these are the key things that we are considering beyond our other strategic shift that we have been able to highlight in our new framework that is almost in the final stages. The next slide, please. So finally, in terms of looking at one of the key target areas that we cannot ignore is that we also want to ensure that our program is expanded to look at areas that are very critical for us. One of the areas is actually AGYW, adolescents and young people, whom we feel that is a very vulnerable population for us to focus on. The other thing is to come up with a very clear agenda for elimination of mother to child, both for HIV, syphilis, and hepatitis as a program. And we have been able to identify this and come up with sections that we will be able to take lead in that. Teenage pregnancies is one of the areas that we really also need to ensure that our effort is considered and we are able to move very well in terms of looking at that direction. Trends in terms of skilled birth delivery, where we can see that currently we are not doing very well. We are at around 64%, and our aim is to reach around 95%. So we really need to ensure that our systems, our capacity for this is well drafted, and also we are able to come up with the effort that is required. Finally, the quality of care, to ensure that we minimize the stillbirths and facility maternal deaths is also one of the key importance. So one of the things that we are doing here is to come up with an integrated program, working with the Division of Reproductive Health and other sectors, and even including child health and other key divisions that are very important, including the EPI, the immunization program, for us to be able to ensure that we minimize and also work together for the benefit of the child and the mother. The next slide, please. I want to reiterate that in terms of STI, this is a program that has been there for long. It's actually, and we believe that is one of the pillars of prevention. So for me to summarize this is that STI is also a program that we have been able to consider in our program, looking at the direction that we are taking. And one of the key things in terms of this program is actually to revive this program, to have a specific case for us to ensure that the agenda for elimination is actually integrated in our STI management. So for us, one of the key challenges that we really want to add is to ensure that the field for STI is well felt for the general population and also for specific population, and also be able to ensure that our mothers are taken care of as we initiate our elimination agenda. So we are also on a discussion and on a run to ensure that the STI program is well revived, and all the support that is required is there, both for commodities, the management, and also the system is well, the capacity is well considered for us to move very well. Thank you. The next slide, please. So finally is the evolving and what we really need to sustain for impact. One of the areas is that as a program, we have been able to look at what do we really need to continue investing in as a program. But also in terms of general outlook is that there are areas that we really require to have immediate innovation for us to have a new way of doing things. And also the areas that require for us to update and come up with the new strategies and solutions within the timelines for implementation. And the question that we put forward is, what do we really need to stop doing in the program that we have been doing, and what do we really need to continue doing in the program, and more importantly, what do we really need to be done differently for us to be more efficient in terms of program within the timeline that is provided. So this is one of the areas that and the questions that we are asking for us to ensure that we have a program that is sustainable and a program that can have a sustainable impact in terms of implementation. The next slide, please. Finally, I just want to say that this program is one of triple elimination is one of the strategic opportunities for us to ensure that we reduce the morbidity and the mortality from HIV infection, syphilis and hepatitis B for our mothers and their infant within the context of universal health coverage. So we are also leveraging on the universal health coverage and also ensuring that our agenda really focuses on ensuring that the reduction in this can also be able to support the program. The last one. Thank you very much for the opportunity to present the Pmtct overview, and I now hand over to the coordinator of the session. Thank you, and hand over. Thank you.
Thank you very much, Dr. Ndwiga. I hope you'll be able to stay on so that you can address some questions that I can already see coming up at the end. As we prepare to listen to Prof. Ndwati's presentation, I think highlights that stood out were that we are now talking about triple elimination, so HIV, syphilis, and hepatitis B, and at least we have started to immunize our children almost globally against hepatitis B. I think as a country, we have done fairly well. Our prevalence has moved from a high of 9.1 to 4.3% overall. But I think it's still key that women remain at a higher prevalence, and particularly women of childbearing age, and that continues to be a challenge. For me, one slide that stood out is the slide that you showed on sources of new infections. And it's alarming when you see that 47% of women discontinued ART, 10% did not even receive ART, and there was a large proportion of new infections during the breastfeeding period. And I also feel that there are many service providers in this forum, and I think we've really felt it in the last year or two, where there have been many gaps, particularly in availability of commodities. So there has been challenges in ARVs, challenges in test kits, especially for hay testing, challenges in us having nevirapine and zidovudine syrup to give our children. So I hope you'll be able to stay on and address some of these gaps. Let's welcome Prof. Ndwati. Professor will speak to the four main pillars of EMTCT. I think look at the more granulated data and help us really assess where are the gaps and what do we need to do as service providers. Karibu, Professor Ndwati. Thank you.
Thank you. Thank you. I hope you can see my slides.
Yes, we can. Thank you.
Okay.
We are on slideshow. Yes.
Yeah, thank you very much. Let's proceed. I think just to remind ourselves on the absolute risk of mother-child transmission of HIV. Many of us are familiar with this slide, but I suspect there may be people who are new to the field. So I thought, let's just remind ourselves that in the absence of antiretroviral drugs, transmission is about 5 to 10% during pregnancy, 10 to 20% during delivery, and also transmission during breastfeeding. Now, what is important is that with the use of combination ARVs, the mother-child transmission of HIV is actually less than 1%. When mom takes their drugs and they're fully suppressed, they will not transmit to their infants. Now, some of the cross-cutting risk factors for mother-child transmission during pregnancy, delivery, and breastfeeding are as follows. First of all, maternal disease status. So women who have high plasma viral load. This happens when you have advanced HIV or newly infected. I'm sad to say that we're still, I'm a pediatrician, and so see kids, we're still seeing children with advanced HIV. And sometimes when they are in the wards, their mothers are also having advanced HIV and not on treatment. Women with low CD4 counts also, and then, of course, if you're unfortunate to have a rapidly progressive illness. I think by far the most important risk factor now is failure to take ARVs for treatment or prevention. And this happens when you're not diagnosed, or there are systems failures leading to drug stockout, and already Dr. Mashari has alluded to this, or this suboptimal retention in care. And the stack bar from the UN late stack bar shows that very clearly. Women who start on the journey and drop out on the way. Then the other issue is a lack of viral suppression while on ARVs, poor adherence, suboptimal ARV protocols, or even resistant virus. The last being the least of the problems. Usually it's poor adherence or a suboptimal protocol. Now, sorry, let's see. What is this happens to me? Okay. Now, breastfeeding is important. In fact, I would say one of the most important medical advances in the 21st century is the recognition that every mother and child, no matter their location or circumstances, benefit from optimal breastfeeding practices. This is a complete departure from the past, when breastfeeding was largely promoted as medicine for the poor. It is estimated that exclusive breastfeeding could prevent up to 87% of the deaths in the first 6 months of life, and any breastfeeding in the period 6 to 23 months of life is associated with a 50% reduction in deaths. And I'll show you some data a little later. Now, across all socioeconomic states, breastfeeding is associated with a higher performance in intelligence tests in both children and adolescents, translating into improved academic performance and long-term economic earnings and productivity. And this actually makes breastfeeding one of the most critical and far-reaching investments into a nation's human capital. We should never forget this, even as we struggle with the challenges of breast milk transmission of HIV. Now, the risk factors of breast milk transmission is in the duration of breastfeeding. Exclusive breastfeeding is associated with the lowest risk. Mixed feeding, defined as feeding the baby with other feeds, including other milks and solids, plus breast milk in the first 6 months of life, instead of breastfeeding only, it's also a risk factor. In fact, it's probably one of the most risky engagements. Then, of course, if breast milk has HIV, it's more likely to be transmitted. When you have breast disease, cracked nipples, mastitis, and these are particularly important. As long as the mother is breastfeeding, it's not an issue just in the early newborn period. And if a woman relactates and then puts the baby back to breast, that is an issue. Actually, just now, I've just come from the ward and seen a child who's had all these risk factors. Mother diagnosed with HIV, started treatment, stopped taking the drugs. She breastfed a little, stopped, and then relactated and started breastfeeding. And just to say that these issues are still with us. Now, these four pillars are the key pillars for prevention of mother-child transmission of HIV. They've been with us for 30 years. We've talked of these 4 things. First, preventing HIV in women, especially young women. 2, preventing unintended pregnancies in HIV-infected women. 3, prevention of transmission from an HIV-infected woman to her infant and reducing infant death. So the intervention in both the mother and the baby. And then 4 is the support for HIV-infected mother and her family to keep the mother alive. I'll talk on some of these pillars and my colleagues will pick up on the others. Now, let's start off with the prong 1, reduce the incidence of HIV in women of reproductive age, that is 15 to 49 years. And we look at our past data, and that is number of new infections among women of reproductive age. If we look at what happened between 2013 and 2015, there was almost a 50% decline in the new infections among women. And the trend for reducing new infections in young women continued even in 2020. You can see 34,000 versus this 39. So this not been such a great drop. So what was the game changer between 2013 and 2015? I think the most important was that we reduced the availability of the HIV virus through the test and treat strategy. And in fact, at that time, when we started making sure, as soon as you diagnose somebody, you start them on ARVs, we were able to achieve a 50% reduction in new infant infections and also in new infections among women of reproductive age. Now, the other thing we did in that time period, and which I believe has contributed to this reduced numbers of infection, is that we reduced the opportunity for risk by increasing age of sexual debut. How did we do that? Our government has been investing in social protection programs. We have compulsory free primary. We are now working on a 100% transition to secondary school. We have sanitary towel programs in our primary schools, and we also have cash transfers to the poorest families. The cash transfers work was underpinned by evidence where they demonstrated that there was a 30% reduction in the prevalence of HIV among adolescent girls in households which were poor households that were receiving a cash transfer from the government. And the cash transfers, when they were doing that study, the households were only getting 500 shillings, but 500 shillings per month made all the difference. That girls didn't go to the street or to the local towns to engage in transactional sets so that they can have pocket money to buy sanitary towels. So, or there are other little things that they require. So these two things, I think, were important contributors to this reduction in transmission. Now, for us to make the next leap in preventing infection, we need to understand who is HIV infected, engaged in sex, and not virally suppressed. And in this context of Pmtct, the partners of HIV negative women accessing MNCH services
Have we lost Prof?
Yes, we have. I'm giving her a call. Just give us a few minutes. Okay. Okay, Prof is having an issue with her connectivity, but she is rejoining us in the next minute or so. So let's just give Prof a minute. And let's give Prof a minute.
here.
Oh, there we go. Okay, Prof, we can hear you, but we can't see your slides.
Okay, yeah, I think you can see them now.
Not yet. And there's still a bit of echo in your sound.
Can you see my slides now?
Not yet, Prof. There we go. Now we can see them, but they're not in slide mode.
See my slides now.
Yes, we can, but the slides are not in slideshow mode.
Okay. 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 Let me sort it out.
Okay. And occasionally there's still a little bit of an echo with your sound.
And then that's okay. Oh. Okay. I don't know how to sort that out. Let me.
I think you can continue as it is. It's fine. We can read.
I'm not sure how to sort that out. But
it's okay, Prof. If
I
we
think
can
you said
hear you, just move from
I was
slide
at
to
the
slide.
where I was talking about reduced the new infections in women and what the game changer was, right?
Yes, yes.
We were.
Yes, that's where we were, Prof, but your sound is not good. Prof, we can see the slides, but we cannot hear you. Yes. Dr. Kenothia and team, or Dr. Christine, are you able to project Prof slides? And then she's going to join on the phone. I think please project, yes, and then we start from this slide. She's joining shortly on the phone, and then she'll just tell us when to move. Sorry about that disruption. Thank you. Prof is joining us shortly on her phone. And sorry about the disruption. I believe we can all see the slides now. Okay, thank you. Let's wait for Prof to join us. Prof is still having an issue with her connectivity. So I will invite our other two speakers to just go ahead with their remarks as we wait for Prof. So I'll invite Dr. Osoti. Karibu, Dr. Osoti. Please go ahead and give your comments on this topic. And after that, we'll hear from Dr. Christine. And hopefully by then, Prof will be back online with us. Thank you, and sorry about that disruption. Dr. Osoti, Karibu.
Thank you. I hadn't prepared many slides because I knew Professor was going to cover most of what I would have covered anyway, and we hope that she joins sooner. I just wanted to highlight a few issues. Let me see if I can share my screen. I'll just show a few slides.
Yes, we can see your slides.
Okay. So I'm just going to highlight a few issues on prongs 2 and 3, but start with some framework that was developed by UNAIDS looking at the 2030 goals that we had, the SDGs. And one of the things that they recommended towards elimination of mother-to-child HIV transmission is that we need to start free. So we start free of HIV/AIDS, those who are at risk, especially young girls, adolescents, and women who are at risk of HIV infection and transmission onto their children should be kept free. And then they should stay free. And if they are not able to stay free for whatever reason, and we lose them during that cascade, then we need to keep them AIDS-free. So they set their goals, which I think Dr. Nduga had already talked about, so I won't go into the details, but just to show that even though we tried to, they tried to meet those targets, they realized that most of those targets were not actually met. For example, their goal was to have less than 20,000 new HIV infections among children by 2020, but by the time they were doing the audit, it was about 110,000 in the focus countries that had high prevalence. So it means that despite everything else that we have targeted to attain, we were not able to attain that. In terms of reaching and sustaining HIV suppression among pregnant women living with HIV, the goal was 95%, but in our focus countries, Kenya included, it was averaging 89%. In terms of staying free, for those adolescent girls and young women, preventing new HIV infections among them, the goal was to have less than 100,000 by 2020. But then in the focus countries, Kenya included, we were at about 220,000. So again, those targets were not met. Male circumcision, especially for young men, again, the target was to reach about 25 million additional men by 2020. Okay, so the numbers that we got was 2.3. So again, we did not do very well as far as male circumcision is concerned. In terms of keeping the infants AIDS-free, in terms of those on treatment for children and adolescents, the targets that were set were also not met. So it called for action. And some of the actions, the rest I'll skip because I know Professor is going to talk about them when she comes back. It's important for us to ensure that we meet this target or surpass them by 2025. So they set new global targets to be met by 2025, and that is to achieve at least 95% in almost all the parameters of interest. For example, for those women of reproductive age, 95% of them should have their HIV and sexual reproductive health needs met. They should be tested for HIV, syphilis, and hepatitis B surface antigen at least once. And in our setting where we have a high prevalence and incidence, this should be done at least twice and repeating one in the third trimester of pregnancy. We need to ascertain viral load suppression. We need to ensure that those who are HIV positive who are not pregnant receive suppression before pregnancy at about 90%. And then we have 95% suppression of viral loads before delivery. And in addition, 95% suppression of viral loads during the breastfeeding period. And furthermore, we also need to align ourselves with the UNAIDS goals of 95, 95, 95 targets for pregnant and breastfeeding women and all their other key members of the population, including their partners. So what are some of the interventions that we have in place to prevent HIV infection for adolescent girls and young women? We need to have appropriate, prioritized, person-centered, and effective combination prevention options. There are so many options that are available now that we should not just sit there as women and young adolescent girls and young women are getting infected with HIV. So condoms are available, PrEP is available, STI screening and treatment should be available. This we are not doing so well, especially in our antenatal clinics. Comprehensive sexuality education should be offered. Access to post-exposure prophylaxis for those who come in time. Economic empowerment, and I would also emphasize human rights considerations, because that sometimes puts our women at a disadvantage, and that puts them at risk of infection. And then male circumcision for adolescent boys and men. So what are some of the things that we can do to close the EMTCT gaps? We've talked about HIV prevention, including PrEP and retesting. But for those women living with HIV, we need to offer safe conception so that they only conceive when they have suppressed viral loads. And after that, we should offer them antiretroviral therapy and other interventions so that we prevent them from having vertical transmission. In addition, as illustrated in this figure, we also need to test their male partners. And this is something that we have not been doing very well. As Professor Nduati had already mentioned a little earlier, that some of our women are getting infected during pregnancy and during the breastfeeding period. So knowledge of male partner status is very, very important because it may help us to reduce the incidence of new infections during pregnancy and the breastfeeding period. Studies done by ourselves in this region show that actually most of the men, if you reach them, they are willing to be tested and they're willing to support their partners during pregnancy, whether they're HIV positive or HIV negative. The other key important thing is to retain these people in care. As you have already seen from Dr. Nduga's presentation, that a big number of these patients, women living with HIV who are pregnant, are lost when they're already on antiretroviral therapy. They either stop antiretroviral therapy or they are lost to follow-up. And that puts them at risk of vertical transmission as well. And then we need to offer testing and care as appropriate. There are infrastructural issues that we need to deal with, like monitoring and evaluation, supply chain, and continuous training of those who are taking care of these women. So I got this illustration from UNAIDS that sort of highlights some of the missed opportunities for EMTCT and what sort of interventions we can have in place. The thing is, we have all the tools we need to achieve EMTCT. For example, for mothers who seroconvert in pregnancy or breastfeeding, to prevent that, we need to offer prevention services that I mentioned earlier, timely access to testing. Okay, this is now widely available, should not be a problem. Okay, and then services for infants who are at highest risk of HIV acquisition. Those who receive no antiretroviral prophylaxis or treatment, they need to have timely access to testing. They need to have timely initiation of ARTs, which is now widely available in our setting. There's no limitation to that as well. And timely engagement in antenatal care, intrapartum care, and postpartum care as well, and offering services to their infant. Now, we have a challenge with those who previously started at but stopped, and retention and adherence is very, very important. And I think this is where we are losing some of these women who are presenting late with exposed and infected children. And for those who start ART during pregnancy, again, we need to retain them in care in addition to the other interventions as well. So this basically shows us that we have options, we have interventions that we can put in place, and we can audit to see where we are failing as far as EMTCT. Thank you.
Thank you very much, Dr. Osoti, for that very concise and informative presentation. We'll go back to Prof's presentation which will be projected for her, but she's available to talk us through it. So we'll take off from slide number 3 where we were before I invite Dr. Karanja. Dr. Kinuthia, our medical education team, please project Prof slides. Asante. Prof, please go ahead.
Yes, okay, thank you. And in fact, Dr. Osoti had talked a little bit about this. So I was talking about what were the game changers in terms of reducing infections in young women. And we talk about the reducing availability of the virus, our test and treat strategy, reduced infections, then reducing opportunity for risk by increasing age of sexual debut. And some of those have been the social protection programs that our government has been paying for: compulsory free primary, 100% transition to secondary school, which is work in progress and making pretty good progress, sanitary towels for girls, and cash transfers to poor families. So reducing the drivers of young women into early sets in the communities. Now, I think the other is now this whole question of discordant couples. We know from previous studies that 40% of people living with HIV are in a long-term relationship with somebody who's not HIV infected. And we need to start reaching partners of HIV negative women, accessing our Pmtct services for prevention. We know that 18% of infant infections are attributed to women who are seroconverting during breastfeeding. Then there's the question of key populations. This is a population we haven't paid too much attention in terms of prevention of mother-child transmission of HIV. But again, I think there's a need to relook at this. Remember, key populations are defined as people who have multiple partners, multiple concurrent sexual partners. They are very important drivers of the HIV/AIDS epidemic. So there have been interventions there. For example, efforts to provide friendly services for women in sex work. We have all these clinics across the city. I think within those clinics, there's need for work around Pmtct. Next slide. Next slide. Now, between 2015 and 2020, we had a 32% increase in mother-child transmission of HIV. And I think the numbers now, 2021, there's a slight drop. And you can see but we also see that we had a drop in the number of child deaths of children of 0 to 14 years. Remember, intervention here is to prevent mother-child transmission of HIV and reduce infant deaths. So this is an area I think we're not doing great. More work is needed. We need to sort out this story of increasing transmission as opposed to reducing transmission of mother-child transmission of HIV. And I'll explore that a little bit more. Next slide. Next slide. Okay, now, between 2015 and 2020, we've had a shift from what we call the pre-DTG era to the post-DTG switch. We have had significant work to try and optimize the ARV protocols for everybody. And in this slide, what you see, if you look at the row of less than 400 copies per ml of virus, you can see we've shifted for the whole population from 61% of people being virally suppressed at that level to 89% in the post-DTG period. If you look at pregnant or breastfeeding women, this is up to 94%. So optimizing your ARV protocol is one of the strategies for improving our prevention of mother-child transmission of HIV. However, as you've seen, though we've improved this, women are dropping out of the service. So working on retention. So the good protocol and retention will take us along this journey of elimination. Next slide. Next slide, yeah. Now, this is the data that Dr. Dwyer presented to us, and I want us to just interrogate it a little bit more. Women are actually staying away, and they're walking away, and the others are not able to reach the services. So we have the data suggests that up to 18% of pregnant women are not accessing antenatal care. And so what does this mean? 2 out of 10 women in Kenya are not accessing antenatal care. So to address this, we need more community level advocacy. We even need to do operational research to find out who is this? Why are they not showing up? In the figure that Dr. Dwyer showed up, I think 3 of the Central Province counties, the former Central Province, the county of Nyeri, I think Buranga was there as well as Kiambu. In terms of antenatal, access to antenatal care, they were in the yellow, supposed to be in green. And there are many others which also are yellow. So what are the issues here? Now, 2 out of 10 women who access antenatal care are not tested. So the issues here are the processes within the facility, the issues of the commodities, and I think also the actors. How are we organizing our services? How is that tough war between the nurses and the lab staff? How is that playing out in terms of access to services? This is what we see. So in actual fact, it's only 6 out of 10 pregnant women who are getting to the point of knowing their HIV status. So for us to achieve that goal of 95% target, we need to have everybody come to ANC and everybody to get to literally know what their HIV status is. And then, so essentially we need to aim for higher targets than actually the global targets that have just been presented by Dr. Osoti. Finally, about 4% of known positive women walk away from our services. You know, they don't even start, let alone start and then not continue. Next slide. Now, the antenatal care and pregnant and delivery care and postnatal care are actually core to succeeding in our Pmtct initiative. And in this slide, just look at some of the numbers on the essential ANC and delivery care package. And you can see that story of ANC and attendance. And then I want to highlight delivery by a skilled birth attendant. We can see in 2015 we're at 62%, but even when you have good numbers for, reasonable numbers for everybody else, HIV-infected women are only about 1/3 delivered within our health services. I think this is an issue. When we don't interact, when we don't get to meet them at the time of delivery, then it's we don't have the opportunity to help address the issues of infant feeding, care for themselves as they go into that phase of post-delivery. I propose that we need to build in a regular survey to provide evidence for programming. It's not enough to look at these numbers and be happy and say, let's do more. We need to talk to women. We need to find out why are they staying away. I had an opportunity to work with the Polio Program, and when this was happening, the global GPI engaged Harvard University to develop a survey that they would periodically apply to actually find out why people are staying, why families were keeping their babies away from polio immunization. I believe now for us to actually make the next step where we truly eliminate, we need to have this kind of regular service, regular pause to be able to find out, to figure out where are the weaknesses in our services, in our service delivery, so that we can actually achieve the goals that we are talking about. Next slide. The study has highlighted the issue of early infant diagnosis. 2021 has been a bad year, and even 2022, we're not doing so well because of the issues of commodities. But even before we got there, we were not doing well in terms of accessing testing for children. Now, these babies are within our services. I have not put in the data here for BCG and Penta vaccine. It's more than 99%. We have very good reach, particularly of the 6-week immunization. So this child has come to the service, but they're not to the facility, but they're not getting the integrated service. There were efforts to link early infant diagnosis and immunization, but we are so married to our program, so we're so siloed in our approaches that effort has not yet borne fruit. But that's an area we need to go back and ask. I actually asked the question, why don't we have a column for early infant diagnosis within the register for immunization to make sure that these children are actually followed up and the testing is done? Next slide. So essentially the child is in the service and then it's getting lost. Now, this is data from Kiambu County, and this is data from the dissertation by Dr. Betty Boro, and it illustrates the challenges for the child. The blue is the 63% are HIV negative children. We know them, and they are on continuing care. The yellow 29% are children who are HIV exposed and are unknown status. Their mothers booked antenatal clinic. They got part of the service, but these children have now gotten lost to the service. We're not sure whether they left the county or whether they just stopped coming for any services, or whether they went to a lower level facility where the HIV services are not provided. But of the ones we know who are HIV positive, about 2% of the children who are non-HIV positive are not on treatment. Just illustrating this challenge we have of continuity of care. Next slide. And Kiambu is one of the really well-performing counties. They have a very good, community initiative. But even in that context, we still have these challenges. Can we see the next slide, please? Can we? Yeah. Now, this is that stack bar by the UNAIDS. I looked at it in detail, and I have those two summary statements. One, 50% of infant infections are of children of women who dropped from the service. Half of them dropped off in pregnancy, the other half during breastfeeding. I feel bothered that you have people who have a chronic illness. I don't think there's any Kenyan who doesn't know just how serious HIV is. You've come to our services, we've even started you on treatment, and you walk away. It means that there's something we're not connecting. We have small surveys that show that up to half of the women who access for example, our HIV services in KNH, now just routine services, have symptoms of depression. Is it that we are not dealing with the mental health issues sufficiently? Is it that we are unfriendly? Is it that our patient flow, the flow of client flow within these clinics is humiliating the women, and so they reach a point of just walking away and giving up? We then have another 50% of infant infections are during breastfeeding. Some of them are from women who got lost to follow up, and some of them from women who are newly infected, and some of them from women who started ART in pregnancy and so are not sufficiently virally suppressed. Again, the point that was made by Dr. Osoti, can we reach a point where women conceive when they're ready, when they're virally suppressed, when they have optimal health, as a way of preventing infection to their infants? Next slide. Now, I put this slide here. It's based on work that was done in Zimbabwe on HIV seroconversion during breastfeeding. In the first row, we show the the mother-child transmission in women who are HIV positive at baseline. So they have antibodies, they were infected, they were not on ARVs. It's 8.9 per 100 child years. Now, if we then look at the data in the next rows of women who seroconverted in the postnatal period, the first 9 months post-delivery, the babies are very vulnerable, and women who seroconverted at that point, the transmission was 34.56 per 100 child years. And then, of course, the rates dropped at 10 to 12 months, and then greater than 12 months, there was zero transmission. At this point, most the babies were not being breastfed. But there was a group of women who were just PCR positive. And in that group, the transmission rate was 75%.
We seem to have lost Prof again. Let me just try and get in touch with her. And as I do that, I think Dr. Christine, you can get ready to make your presentation. Let me just reach out to Prof.
Shall I go ahead?
Yes, again, just give me a minute, Christine. Christine, please go ahead as Prof tries to join us in the next few minutes. And I'm really sorry about this disruption, but I can see there's so much learning we're getting from Prof. Let's give her a chance just to rejoin. She's having connectivity issues. Dr.
Okay,
Karanja,
go ahead.
And as Dr. Karanja makes her presentation, please continue to post your questions in the Q&A. We'll be addressing them shortly after this presentation. Thank you.
Okay, I don't have slides. I would have wished to have my video on, but that is okay. I seem not to be able to do that because there was something I wanted to show, but is somebody able to?
I think that can be enabled. Dr. Kennethia, can we allow Dr. Christine to enable her video? Agnes, can we enable Dr. Christine's video? Go ahead, Dr.
Yeah, so I don't have slides. A lot has been said from prongs 1, 2, 3, and mine is prong 4. And this is, okay, let me start my video. Yeah, so this is about reaching the mothers, yeah, about keeping the mothers alive. And here, I think perhaps this might be the most important prong, especially in terms of advocacy. Because in order to keep the mothers alive, we really have to rope in all players, all hands on deck in order to keep the mothers alive, because when you keep the mothers alive, then you keep the babies alive, and it goes on to the whole generation. So the reason I wanted my video alive, not alive, but on, is to show this book. You can all see this book. I think this is one of the best books I have ever found on comprehensive care of the mother and child. It begins with a letter on page 1 on the cover to the mother and father regarding their pregnancy. It's father and mother. And then at the end, it's a letter to the baby, the owner of the book, who was handed, who the mother was pregnant with and was given the book. A letter that you are now a grown-up and this is a story of your life in this book. So it's a very, very, very good book. Then the other page I wanted to talk about is a page that maybe some of us don't look at. The page where when you as a pediatrician, because I am a pediatrician and Marie is a pediatrician, Prof is a pediatrician, and perhaps there are some other child health workers. When we are seeing these babies, you should always stand back and look at the antenatal profile, because that will tell you whether the mother was tested for HIV, whether the hepatitis B, and VDRL for syphilis. So sometimes you will not even need to ask. And I saw in the chat somebody inquiring about private sector. That is one thing the private sector is failing. And it is my opinion that this book should be made compulsory in all health facilities in Kenya. We should do away with the cards that only have one page for charting growth and a few vaccines, and have a comprehensive book that shows the pregnancy and the baby issues, because that is the first and foremost aspect of longitudinal care. Because if you're going to keep the mother alive, you have to incorporate comprehensive longitudinal care. And this care should be family-centered, because the family is not just made of mother and children. It is also mother, father, and children. So what are we doing about the father? Issues of disclosure, need to be addressed. Issues of a family-centered care, not just HIV, but other aspects of care, other aspects of sexual and reproductive health, other aspects of nutrition of the child, and other aspects of even gender-based issues. So that is one aspect of comprehensive care. Then the other thing, and I think Professor Duarte may have alluded to it, we need to find out what is keeping our mothers away, Could be, even as we interrogate that, are our services well integrated, or are we telling these mothers, you HIV positive people, go into that corner and then shuffle back to this other corner, but we need to integrate our services, a one-stop shop. And then again, I will rope in the adolescents, Adolescents are now our young mothers, and they could be responsible in a way for the slight surge that happened on the Pmtct at some point. So we have young adolescent mothers lost, not getting care. A HPV introduction into the system has given us an avenue to bring these young adolescents from 10 years old into the system. So we need to find which other programs, which other packages, which other health packages can we bring in for this largely ignored group. And of course, all this will need our partners. Who are our partners? The government is a big one, but the government cannot do everything. We need our civil societies. We need other global partners. And of course, we cannot forget community participation. The counselors, the peer support groups, all these are resources that we need to mobilize. And as advocates, we must be willing to put our voices out there in terms of making sure that longitudinal care is cascaded down. Again, mental health issues, very prevalent. You've seen the rate of homicides, the rate of depression, suicides and everything. What is happening. We need to take care of the mental health issues of our mothers and basically of our families. Now, in closing, because I don't have slides, but I just want to say, like in many aspects, sometimes the majority are doing well, but there are clusters of marginalized people. So who are these marginalized women? It could be marginalized in terms of religion, certain religious sects or affiliations, educational status. Their areas of residence, maybe they are living in low-income areas. Their occupation, I don't know if to call it occupation, the commercial sex workers, the intravenous drug users. Yeah, so we need to find these small pockets of marginalized people and find strategies for them to have inclusion. So that is all I have to say about Prong 4, and I will just switch off my video. You can stop seeing me, and then I give you back, Anne-Marie.
Thank you very much, Christine, for that presentation. And I particularly love highlighting the importance of that mother-child booklet. And I think we should confess that as healthcare providers, we are part of the problem because we don't ask for it. So the mothers indeed don't think that it is an important booklet. It's unfortunate that we've lost Prof as we wait for her to see whether she'll be able to join us. Prof, I believe you're back. I don't know whether you'll run through your final slides before we start taking questions. I know you only had 3 or so slides remaining.
Yes, let me do so. I'm so sorry. This is like playing dodge, but I'm here now. I'm on my phone. I can, and if you run the slides, I will just quickly talk about them.
Thank you. Thereafter, we'll start taking questions. So please continue to put your questions in the chat. Prof, go ahead. Thank you.
Yeah. So this slide, I don't know what you got or didn't get, but the key message here is that women who seroconvert transmit very high transmission rate. You can see among in the first 0 to 9 months for women who transmitted, the transmission was 34.56 per 100 child years. And if you go right down to the last row, women who are seropositive and who even just were PCR positive, the transmission rate was 75%. And so it's, in fact, and this has been the finding even in other studies, so that by the time you're actually catching up with the mother at she's positive because you're doing you have a positive antibody test, it's probably too late. Her baby is already infected. Next slide. Now, this next slide shows you the viral load when somebody is has newly infected. You can see in the first 3 months of being infected, the amount of virus in breast milk is almost the same as in serum. So the breast milk is highly contagious to the infant. It does drop with time, but still very high viral loads. These are sort of, you're talking about 2 log, 3 log. In fact, in the first 3 months, you're talking of 4 log viral load in both breast milk and serum. Next slide. Next slide. Next slide, please. Now, we talked earlier about women are getting infected from their partners. This is our data. In 2015, only 4% of partners of HIV, of women, pregnant women, will actually get tested. Now, to prevent new infections, we must reach men with the testing, and we need to look at new ways of reaching them. We now have experience with this experience from research of giving self-testing kits to partners of positive women, and their uptake is fantastic. I think we need to try and do this now for partners of negative women, because we want to prevent infections. And I think as a program, our programs go forward, there should be both research as well as programming around this. I don't think bringing men into the ANC is working very well. It increases the workload. You're not increasing the number of staff. when you come and fast track men, it leaves everybody else feeling bad because they have been waiting to be seen. So innovative ways of reaching partners of women who are accessing our A&P services is important. Next slide. Next slide, please. Now, this slide is important. We need to reboot on what we call virus suppression. This slide shows very interesting data. It's based on a recent study in Botswana. They looked at virus suppression, redefined it, less than 40 copies per ml, 40 to 1,000, and more than 1,000. In our country, we've been using 1,000 as the cutoff point of virus suppression. You can see that the mother-child transmission of among women with less than 40 copies per ml was 0.9%. Between 40 to 1,000, so that's just sort of low-grade viremia, transmission was 7%, and 8.5-fold higher risk of transmission. And if you look at those who are not suppressed, you can see that the transmission rate was up to 14.4%, a 17-fold increased risk. And when they looked at their population of who was having suboptimal adherence and hence having this low-grade viremia, they were able to identify that adolescent girls, women who have been on ARVs for less than 6 months, and women of lower education status, pointing to maybe the women of lower education status poorer understanding of what is required, or maybe living in socioeconomic status where they are much more vulnerable and having less control over their life. For the adolescent girls, it's just maybe not mature enough, not grown up enough to see the importance of taking their ARVs. Next slide. So based on this data, our program needs to change. We need to be able to say that virus suppression is less than 40. We work with the lab to make sure that they can give us data like that. Now, this slide, which is almost among my last slides, is looking at breastfeeding and mortality or HIV infection by mode of breastfeeding. And I want you to pay attention to just the last column, really. And again, recent data from Botswana. Now, if you look at the last 2 rows, women were randomized to 6 months of breastfeeding or randomized to 12 months of breastfeeding. Women who breastfed for 6 months, the mortality or HIV infection of their infants was 3.9%. For those who are randomized to breastfeed for 12 months, the mortality or infection rate for their children was half the rate of those who are not breastfeeding. So again, confirming what we've known, that the HIV-free survival of breastfed babies is good. When the mother is taking her ARVs, it offers the baby the most optimal chance of survival. Next slide. This slide then is sort of like summarizing that data on babies. And the steps are HIV-free survival. I'm alive and I'm not HIV infected. The lowest HIV-free survival is among newly infected or unidentified newly infected mothers, okay? They have the highest infant transmission rate, and we know that infants who are HIV infected, you haven't identified them, so you haven't put them on treatment. They have very high risk of mortality. The next step up is mothers who have chronic HIV infection and not on treatment. And we saw from the UNAIDS staff bar that there are many women who are dropping out of the service during pregnancy or during breastfeeding, and this undermines their baby's survival. Then the next slot are women who are not virally suppressed. I've just shown you the slide of suboptimal suppression and its impact on mother-child transmission. The best is when mothers have attained a viral suppression and they have sustained viral suppression, We've retained them with our services. And when we do that, we'd expect a 97.1 HIV-free survival. Actually, just slightly lower than the survival of children who are not HIV exposed. Next slide. So I want to leave you with this thought. Where are the lost women? Are they really lost, or they are just invisible to the providers? We need to look for corroborative evidence from our immunization programs. Why are women walking away from our services? Are the services really available? This is my parting shot to all of us. I apologize that I've had all these challenges with electricity today, but I hope I'm here to answer questions that you may ask. And with we have a very good panel for this discussion. Thank you.
Thank you very much, Professor Ndwati, Dr. Ndwiga, Dr. Osoti, and Dr. Christine for excellent presentations. We have just about 15 minutes for our Q&A. So I'll just go ahead straight into the questions as they are, and then the speakers can go ahead to address them. So the first question, which may go to Dr. Christine or Professor Ndwati, how has the introduction of pentavalent vaccination in the routine public vaccine schedule reduced prevalence of hepatitis in children? Are there plans to introduce birth hepatitis vaccine as well for routine schedule in public facilities? Please go ahead.
Let me say hepatitis B, birth hepatitis B is something we need like yesterday. It has not yet been introduced. In fact, global data shows that I think in Africa, we are really lagging behind with the birth hepatitis B. It's at 4%. And that would be a strategy to reduce hepatitis B transmission in our babies. But that said, the hepatitis B as part of pentavalent is doing very well. But we will remain to see that from the people who started getting in 2001, now when they become mothers, we will look at the transmission of hepatitis B to their babies, whether it will go down. I haven't seen that data yet, but definitely there is an impact. That remains to be studied.
Thank you. Dr. Osoti, there are a number of questions looking at our ANC facilities, and I'll just read through some of them. One of them is asking, at 63% syphilis testing at ANC, what is being done to increase testing? Along with that question, there have been questions about the role of Pmtct in the ANC services, and perhaps you can also address that. And sorry, what is the role of PrEP in mother-to-child transmission, in elimination of mother-to-child transmission? Could you address the questions on PrEP and the syphilis testing? Thank you.
Okay, thank you very much for the question. So syphilis testing should be universal, and most of the facilities are able to offer the testing. We also now have dual testing, and I think Dr. Ndwiga can contribute to that as well. Dual syphilis and HIV testing kits are also available, and that will increase the number of women that are being tested for syphilis in the antenatal clinics. I think the challenges we have had in the past is just because of lack of reagents, and that also applies to hepatitis B as well. So lack of reagents, stockouts, and things like that, which I think the government should be able to address. So that's the main issue. Otherwise, for most of the private institutions, for Kenyatta National Hospital, MTRH, and other major hospitals, there shouldn't be a problem. But in the smaller facilities, there may be stockouts that need to be addressed. PrEP is also available, especially if you can identify the women who are at risk for HIV infection. You can be able to offer them pre-exposure prophylaxis, especially in the antenatal clinic. The safety of that, of course, has already been confirmed through many studies. So I think it's just important for us to roll it out, maybe to find a standard tool that we can use universally in our antenatal clinics to identify the women who are at high risk of HIV infection during pregnancy and the breastfeeding period. Just like Professor Ndwati had mentioned, issues to do with depression as well. If we don't screen our women to find if they have these conditions or risk for getting depression or HIV infection during antenatal period and the breastfeeding period, then we may not be able to offer the services to them. So we just need to implement these interventions. Thank you. But I would want, from a programmatic point of view, Dr. Ndwiga to give some comments on that as well.
Yes, and as you comment, Dr. Ndwiga, I'm just wondering, Dr. Osoti, is there even awareness that there's such a thing as PrEP for the women who are attending our ANCs? Do you have any comment on that, Dr. Ndwiga?
Thank you very much. Thank you very much, Dr. Osoti and the professor. I think one of the key things that we are doing, and actually we are in one of the workshops, is actually to develop material, both job points and both for community and health workers to be able to create awareness and ensure that we are able to create demand, and we are also able to ensure that the communities are aware about those services, and also working at a level of ensuring that we are able to scale up this program and this more specifically to our MCHs. So that is one of the key agenda that is taking place in terms of program direction that we have been given, and also in terms of improving the program performance. Also in terms of testing for syphilis, I think one of the key things we have been able, has been highlighted by Dr. Osoti, is all about the commodity. And one of the things that we have been able to do, led by NSCOP and also the ministry and the directorate led by Dr. Murwa, is to come up with a very well-defined commodity sustainable and the commodity security plan for this country, more specifically within the priorities of Pmtct and even other areas. Also looking at how we can also be able to come up with a resource mobilization strategy, and also be able to see how we can be able to integrate our program, our Pmtct, more specifically to the Reader Mama program, for the lower facilities that may be having our VDRL test, but when you are able to provide those services to our ANC, they go at a cost. So those are some of the strategies that we are trying to do, looking at other options of how we can be able to build this program further, looking at the opportunities that are there. Thank you, and over.
Thank you, Dr. Ndwiga. I think that issue of commodity has come up both as questions and as comments, and particularly that last year has shown us how fragile the state is, and indeed how much our own government is, how little they actually contribute to that particular health agenda, despite it being one of the top 4. So we indeed hope that we'll have more security of commodities. I know that you may not be able to give us a lot of details. While we still have you, there is a comment/question on HIV prevalence reduction has not been very impressive over 20 years. The mother-to-child transmission reduction, while it appears big, but with all the efforts to date, there's actually less MTCT. And also that drop is not very big. As Prof shows us, there's actually been an increase in the last few years of, I think, almost double. So the persons living with HIV have reduced, but not by much. Can you explain this drop? When you consider that the prevalence has gone down and the potential attrition, shouldn't we have a much lower prevalence of HIV? I don't know if the question has come across clearly. Dr. Ndwiga?
Thank you very much. I think I just want to look at it in 2 ways. One is that what effort are we able to put in terms of looking at where we have come from and what lessons have we been able to run from this program? And I would like to say that if you look at our data, which had given the journey, we have come from far, our efforts have been there. But more specifically, I want to say that if you look at the data in terms of the program implementation for 2012, we are at a level of around 16% in 2012. And in 2021, we are at 9.7%. But more importantly, I may also say that with the effort that has been put within the preliminary data that we have been given, is that the program, we are at 8.4%. So what I may say is that what are these challenges? What are the lessons that you have been able to run? And I may also say that some of the key highlights from our technical team, our technical work group, that we were able to have a meeting yesterday, and what Professor Duarte and other members were able to highlight, is actually to look at what are the key interventions that are new, and what are the key strategic shifts that we really need to undertake. And as Dr. Osoti and I highlighted, we need to look at issues around our commodities, one of our key challenges, are issues around the training component that we have being one of the commodities. And then finally, are there challenges in terms of also the data that we have? So those are some of the systematic issues that we also need to look at, as we also look at what are the new ways and interventions that we are going to ensure that. But more importantly, I may also say that there are lessons we have learned. There are key things that Professor Duarte has been able to highlight that we also have been able to consider in our new framework that we are almost finalizing with our technical team moving forward. Thank you, and over.
Thank you very much. Dr. Osoti, I think we've highlighted the challenges we've had with ANC a lot throughout the presentations. There's a question here: what is being done to increase the ANC uptake generally, and especially in the first trimester? Are we also reaching out to private facilities and specialist consultants? And what is the uptake in terms of provider-initiated testing in the private facilities?
Okay, thank you. I think the issue of private care providers has been raised a few times. There are different cadres of private care providers. So you'll have, individuals providing care like consultant obstetricians or medical officers or any other doctor or any other nurse in that matter. And then you also have facilities like nursing homes or institutions like that. So I think for most of the facilities that have delivery services, antenatal services, there's almost, universal testing, but maybe some private facilities or private practitioners may not have that universal testing. However, what some of the facilities have done is that, when patients go in to deliver, at least they have a recording somewhere, and those who have not been tested can be offered HIV counseling and testing. So I think at a programmatic level, the ministry should just task the private institutions to be able to at least offer some statistics of the proportion of patients who are tested and those who are HIV positive and all that. Initially, there was a lot of stigma around testing, and that's why some of the private facilities were not taking it up. Also, there was the issues of training and all that, but because of the opt-out approach, now it's not a big issue because patients are routinely tested, and those who are positive are then offered testing. We wouldn't say that private facilities contribute to a big chunk of or proportion of those whose HIV status are known and who eventually, as a result, end up with vertical transmission, because these are patients who are definitely accessible to care. I think we should worry about the other facilities, government institutions, or other, smaller facilities where patients, for whatever reason, are lost to care. They don't come for antenatal care and all that. So, and we need an operational research, as Professor Duarte had mentioned, to find out exactly where the lost women are in antenatally and in the postpartum period as well. Thank you.
Thank you, Dr. Osoti. Prof, I'll give this question to you. I know we did not go through the details of the guidelines, but Prof Butt is asking, is one-time testing during pregnancy enough? And together with that, the question, immediately after delivery, must we give zidovudine and nevirapine to the baby before starting breastfeeding? Maybe we can answer that for those who have not seen the guidelines or are aware of them.
So the testing for women, once is not enough. If we test you and you're negative early in pregnancy, we want to repeat it in 3 months, and we want to repeat it at the time of delivery, and we want to do it every 3 months as you are breastfeeding. This was sort of the strategy for trying to catch up with women who are at high risk, and also knowing that the process of testing is actually an intervention in itself in terms of reducing the risk of infection. In terms of ARV for the baby, you want to start the ARVs within the first 72 hours after delivery, and preferably sooner than later. So preferably within the first few hours after the delivery of that infant. And we don't have any rule about it, whether it is before starting the fast breastfeeding. I think they're initiating breastfeeding within the first hour of delivery is important because the physiology of breast milk starts altering. We need to start breastfeeding early to be able to stimulate production and to sustain good breastfeeding. But please, the ARVs should be given within that first 72 hours. Again, commodity, the challenges of commodities have been that we started running out of nevirapine. So there are many babies who did not get their prophylaxis the way they should have throughout the period of breastfeeding. And some of the discussions we've had in different forums is that it's a question of whether we shouldn't be manufacturing our own nevirapine, you know. Making this agenda of eliminating mother-child transmission of HIV, stopping to be just a Ministry of Health or a health sector agenda. It should be one of those flagships that all Kenyans feel that they are protecting their infants, we are protecting the next generation, and we're doing everything possible, including becoming self-sustaining with for the essential commodities that go towards that prevention. I want to take you back to the question of syphilis screening. You know, this end user fees business is one of the barriers to routine syphilis screening. Facilities want to charge for what they call the screening package, and the charges are out of reach for the women. The other is the way we deliver, we organize the ANC. Do we have an integrated health worker who provides you the whole service? Or do we ask people to follow a supermarket kind of approach where you go and sit on several different benches to get your service? If you're asking people to move from one place to the other, to wait for services, they go away. This is when they go away because they get their card. They know at least I have a card. If I have a problem, I won't be chased away. But they didn't get the service because the service was not well organized. So we need to address. We need to be patient-centered. We need to be patient-friendly. We need to ask ourselves in our little facilities, what is the optimal pathway for this woman, so that you actually get the whole package of services. I also want to comment about the private facilities. There are very, very many little facilities, the ones that we refer to as Kaprivatingine Hapo. You know, you ask a mother, where did you take your child? Kaprivatingine Huko in the Kijiji. Those facilities are not providing the care package that is required. Over the last few weeks, we've had children who are HIV infected in the ward, and when you follow through, the mother did go for antenatal clinic, but she went to another Kaprivatingine Hapo. And unfortunately, those facilities usually have one health worker. They cannot leave. They cannot leave to go and get trained to be updated on what current guidelines are, because if they go, then the facility closes. So we have to find ways of reaching those facilities and ensuring that people are getting quality of services. Thank you.
Thank you very much for those remarks, Prof. And I think on that note, in view of time, we are going to end our presentation. I'd like to thank the presenters very much for the very detailed slides, Prof. The slides I think you gave us had so much information in them. We really appreciate the time taken by all of you to prepare and make time to be here, as well as the participants. We had well over 900 participants, even 1,000 with all the technical hitches we had. Thank you to the medical research team for the support you've given us through this CME as well. Thank you, everybody, and good afternoon.
Thank you very much, and thank you for showing up to listen to us. Thank you.
Thank you.
Thank you.
Yeah.
Thank you.
Yeah. Okay. Bye-bye.
Bye.
Okay, thank you.